myself and my senior colleague, postgraduate students and my dear friends. Today I am going to talk on echocardiography. It is one modality of cardiac ultrasound. In last week in our hospital, we have already discussed this year was declared as a year of ultrasound for 2013. So in the series of that I have started this, try to give some basics regarding the echocardiography and some interpretations. As we know, it is one of the important tools, and last around 50 years, this is one of the tools which is been very much practiced in clinical cases. So let me begin with the first, that what is the echo? Basically, echo is something when you are experiencing all the times. Suppose you are shooting in the wall and we are getting, you see that the same sound is reflecting back and at the bottom of the wall. So similarly, this is the applies for the principle of your ultrasound. What happened? Basically, echocardiography is a type of ultrasound that uses high-pitched sound to produce image of the heart, and the heart sounds are sent through a device called transducer. And this transducer is basically having part of the various part like your crystals, probe, and this is the impulse generated, and it is the giving the sound, ultrasound, and this is the piezoelectric crystals, and there is an interaction between the crystals and skin which the jelly we are applying, and then this is the sound wave, it is hitting the organ, coming back and then reflecting in the image. So basically this sound, when we are applying the gel and then the reflecting on the various then returning and giving the pictures like this when we are taking. So what is the basic physiology here? The transducer which is producing the mechanical energy is into converting in electrical signals which is display and gradually conversion of sound to electrical energy, and this effect is we know in physics known as piezoelectric effect. So this is the basic principles for the echocardiography for the interpretation. Now the part of machines, the basic part of the machine, the basic part are the 5 basic part of the machine. The first is the pulse generator, which is applying the high amplitude voltage to energize the crystal. Then the transducers, and which is converting the electrical energy to mechanical energy. And the receivers, which detects and amplifies the weak signals, and display, and finally the memories. So these are the 5 part of the hardware of the different part of the machine. Then the basic modalities. We know there are transthoracic and transseptal echocardiography. These are the 2 common modalities for this. And here we know the transthoracic echocardiography is the most non-invasive way for. The position should be semi-reclined, and left arm is tucked under the head and right arm lies along the right side of the body, and standard position of chest wall are used for the producing the transducer, and this is typically known as the echo windows. What happens? The windows, we know common windows are here in the diagrammatically say this is the parasternal windows, and this is the apical, this is suprasternal, and this is the gp-sternal. These are the 4 common windows we are using for the clinical day-to-day applications of the echocardiography. Now after getting a good window, there are many views where we are examining the, and most example in short it is known as the flax view, that is parasternal long axis view. If you see carefully, your most common is the space is between your second to fourth intercostal space, and the position of the dot should be your left, your towards the right shoulder, and most echo begins studies with this view, and most of the subsequently what you are getting here. See, if you will carefully see this is the view we are getting here. It is the left atrium, this is the left ventricle, this is the right atrium. So this is the right atrium, and upper is the your down. This view is the RVOT. So we see upper part is the your aorta, and this whole view is the one important view whether you can see all the four. We can see LA. This is the your LA. Then immediately we see this is the LV, and this. Next view is the short axis view. When we are seeing the Black's view, then the short axis view, we can see the various picture. We are seeing the aortic valves. We are seeing the carefully. If we see when your hand should be the twisted, the same view, so that we can see the at the level of mitral, at the level of the aorta, at the level of papillary muscles. These 4-5 view we can see on this. Here the your marker of the dot, that when transducer there is a dot, and that is the position, and this is the technique and skill through which we can easily move our hand in the various short axis. So after parasternal long axis, we have to take short axis, and again short axis view is at the level of aortic view, at the level of mitral view, at the level of papillary muscles, LV muscles. These are the 4-5 views we have to examine the short axis view. Then this is the, you see there are the papillary muscles, anterior papillary muscles, and this is the, you see here, this is the your anterior papillary muscles, this is the posterior papillary muscle, this is the RV, and this is the your short axis. Now the most common view, it is the apical 4-chamber. This apical 4-chamber view is the common whether we can see the LA. Here we see LA, you see LV, you see RV, and you see RE. And this is a tricuspid valve, this is the mitral valve, and you see apex. So this is the classical view for 4-chamber view, whether you can see the altar. At the same time, apical 5-chamber view is very important for seeing the aorta. So aorta, how here you see this is the aorta. This aortic valve, when we are tilting our hand to this, so that will be giving the rise to the apical 5-chamber view. So these are the most common view. Every patient we have to examine for. Second is important view for seeing the wall motions for the apical 2-chamber view. Here what we see, the LV, and this is the basically anterior wall and inferior wall. So the assessment of the anterior wall, inferior wall is very important, and here you have to your dot direction should be left side of the neck 45-degree anti-clockwise. So this is the view for the apical 2-chamber. Then I already told you there are basically the subcostal and supra. Here it is the subcostal view. When you are marking dot, basically point toward the left shoulder, and patient should be left supine without pillow, and feet on the bed, knee are slightly elevated, and better images are obtained by the abdominal should be relaxed during inspiration. And in this view, interatrial septum, particularly it is a very important for the septum and pericardial effusion, descending aorta. These are the view whether we have to examine subcostal view. And this is the last window, that is the supraesternal view, and here we have to put in a probe in the above in the supraesternal area, and the pointers here you see the point towards the left jaw, and we can see in this position that most of importantly related to ichocordia. So this is also one view whether we have to examine. So these are the common windows where we have to examine. We know all the valves. The echo is the basically structure relating to the structural and functional abilities of the heart, whether inside the anatomical different view of the valves, wall motion, chamber size, pericardiums, pressure gradient. These are the 5-6 parameters we have to always concentrate regarding this. So heart valve, you know, these are the most important. Two groups of valve are atrioventricle and semilunar valves, and these are the common. These two, when this is the RA, so RV, when this is the pulmonary and mitral, and then this is the aorta. These 4 valves and their anatomy, is it a normal? Is it abnormal? Is it stenosis? It is a regurgitation. Is it, what is the pressure gradient? Every cases within seconds we used to assess. Is it a normal? Abnormal. So all the valves between various sides. So basically, heart is a pump. It is a modified muscular special properties having the pump. All right. So this is the basically the heart is the muscular pump, and you know the basic function of the heart only stops once in life, that is the in the end of the life. Thank you. So this is the mitral valves. This is the your pulmonary valves. This is the this is the mitral valve. This is the tricuspid valve. This is the your pulmonary valve, and this is the aortic. All the right-sided, you know, 2 chambers. Importantly, the right side and left side, both sides are very important in the hemodynamics. Earlier days, for getting, for example, related to pulmonary valve and their pressure gradient, used to do the invasive procedure, and it is under the different right heart studies, and the Swan gauge catheter was put inside the heart to know the gradient and various pressure gradient. But now it is a non-invasive method for putting the gradient and getting very immediately. Then the atrioventricular valves. These 2 are the common valves, and the valves are the basically for example mitral valves. Mitral valves is having attached with auditory and papillary muscles, and these 3 are known as subvalvular apparatus. And when they are at the end of the systole and diastole, what is the exact pressure gradient across the valves, and that is a very important part. We have to get the information in this. But specifically, we see when we are examining mitral valve echocardiography and concentrating only on the mitral valve, we have to know the basic anatomical structure. That this is the part of annulus valves, and this is the cauda tendineae, and this is the papillary muscles. So these 2 are the 2 cusps, anterior mitral valve and posterior mitral leaflet. So this is the typically of that. And very interesting why it is known as mitral, so because it was the name of mitral was why it was named, because the shape was the bishop's mitris, a type of hat shape. That's why this was mitral named as the mitral valve. And the tricuspid because it has having 3 cusps, so that it is. So if there is a pathology like your most commonly like rheumatic heart disease, which leading to mitral stenosis, mitral regurgitation, or congenital changes in the mitral valve, or elderly geriatric patient regurgitation, or DSM leading to annular dilatation. So many conditions, there will be abnormality of the valves, and this which you have to look for them. Then the tricuspid valves, similarly, this is the tricusp, and it is having 3 cusps: anterior, posterior, and septal. These are the 3 cusps, we have to see. Although in transthoracic echocardiography, it is difficult to be as comfortable as the operator in mitral valve than the tricuspid valve. Because tricuspid valve anatomy is slightly difficult in right, particularly in 2D, but in 3D is we are getting a very clear cut picture of the tricuspid valves also. So these are the seminular valves of pulmonary and aorta, very important valves, and both we know the seminural valves. Why? Because its shapes are like a half moons. That's why it is known as semi-lunar valves. And these two valves are important and it differs from the mitral and tricuspid because they don't have a aortic tendon. So they are the important part in the valves of the. Regarding the aortic valves, you know the 2D, this is the aortic valves. So we always used to calculate aortic valves diameters, then aortic cusp separations, then your atrial and aortic ratio. Again, this is the three cusp: right coronary, non-coronary, and left coronary cusp of the aortic valves. Again, many important conditions, and nowadays, in particularly in geriatric medicines, a lot of patients or geriatric patients having an aortic valves sclerosis leading to stenosis, and elderly age that is the important. Earlier, the aortic valves again involving the rheumatic heart disease and most of the disease related to some congenital disease related to root dilatation like Marfan syndrome and other changes, whether it is the root of the aorta is very important. So these are the valves, all the four valves we have to keep in mind. Pulmonary valves, as I told you, is very important, particularly in early congenital heart disease. Every cases because of the pulmonary PS is more congenital than rheumatic. In rheumatic heart disease, pulmonary valve is very rarely involved. All the most common is mitral, second is aortic, third is your tricuspid, and very rarely is the pulmonary. But in congenital heart disease, cyanotic heart disease, most common valves involved is the pulmonary valve. So pulmonary valves in pediatric is a very important, and we have to see again they are having two cusps, and posterior, anterior, and right cusp. So we know systoles and diastole, these are the steps here. Then the modalities of echo. What are the modalities? What we are practicing in Southeastern our hospital. Here we are doing the 2D, M mode, and Doppler में all the three Dopplers, color Dopplers, PW and CW. These 5 modes we used to practice in every patient. But besides transtherapy, transesophageal echo in special cases we don't have a probe, but in future we will establish transesophageal and as well as tissue Doppler's echo and stress echo, contrast echo, and there are many fields of it. Become a part of subspecialty of cardiology. Whether there are more than 12 to 13 modalities of echoes have already came into the picture, including 3D and 4D echo in last 10 years already established in the clinical practice. So these are the modalities of the all modalities. We have to quickly assess the this 2D echo. We know technique. 2D echo was developed in 50s, and the simple principle ultrasound we know that when we are scanning the combination of reflected signals of image, and it appears as I have discussed in earlier that is forming the films. In M mode echo is M means basically motion mode. So M mode echo is basically not a picture, rather it is a diagram. You see, this is your IVS, intraventricular septum, and this is the posterior the posterior wall, free LV wall of motion. And when this is the mitral wave, and this is the M pattern of the anterior mitral leaflet, posterior mitral leaflet motion. So when we are seeing your diagram, we are in that, suppose it becomes flat completely, means there is a wall motion abnormality in that. So this way you used to calculate the M mode. It is the first echo mode, and very much developed by the William Figgenholmes, who was regarded as the father of echocardiography. I got the opportunity to meet with him. He was in Delhi, Figgenholmes. I have interacted with him we have a he's a very knowledgeable man. Throughout the echo world, he was regarded as the father of Pitama. Whenever he used to speak, all the more than 3,000-4,000 echocardiologists who are in India, they are respecting him, listening him, and any word from his mouth is basically gospel. So he developed these two technicians was Sanya and Chan. There were so many in US in various institutes, and finally it was been this mode in last 40 years is the most commonly practice mode in the throughout the world. Doppler echocardiography, equally I told you this is the basically color flow continuous beta. Basically PW for the low flow velocity like mitral, CW for high flow velocity for aortic stenosis, and this is used for that. And red and blue, basically color is the red and blue. Formula is the BART, means the basically blood to red towards and blue away. This is the formula for this, and accordingly, suppose this blood is going to from this to this side, so here it is the regurgitation. So there is a regurgitation of the LA to LV, so LV is regurgitation, so mitral regurgitation is there. Similarly, there is the Doppler calculation with the velocity regurgitation, systole and diastole. So we used to calculate it, is very important for the pressure gradient, because whole practice now depend on the PG, how much it is the pressure gradient, outcome, prognosis, and regarding to treatment facilities. So basically here you see the conclusion is that the echocardiography is basically structural and functional information of heart. It has a fixed indications whether we should know the anatomical detail as well as the dynamics. The quality of echo is highly operator dependent, and the experience and skills and value of information we have, because it is an indirect evidence of the disease. So we have to very much concentrate that is it a normal, abnormal. It is a fact for me. It is a normal pitfalls. What are the pitfalls of that? What is the differential imaging diagnosis of that? What is the clinicals of the patients? And then finally we have to give the reporting with this. So this is the important part of basics. Some pictures are moving, still pictures have brought that these four